Respected seniors and my dear friends, very good evening. Hearty welcome to all of you for yet another teaching session hosted by IAP Kozhikode on behalf of the PG training program of Action Plan Synergy of dear President Dr. Joseph. I Okay, sir. I invite President of IAP Kozhikode, dear Dr. Professor Ajit Kumar, sir, to tell a few words. Ajit, sir.
Yeah, thank you. As a part of the continuing series of case presentation for PGs, today we have a very interesting case, which is usually kept for exams, both DNB and MD, as a short case. And as you know, this is being chaired by none other than our Dr. Mohandas, who has maybe at least 20 years of experience in clinical genetics, who runs the genetic clinic here in IMC. He running the genetic clinic at IMCH, and we have Dr. Shamim from Assistant Professor Department of Pediatrics, and Dr. Shamim is an intensivist and also interested in respiratory medicine. So I thank both Dr. Mohandas, who is now currently the HOD of Idiki Medical College, Department of Pediatrics, as well as Dr. Shamim for chairing the session. And we have our own one of the brightest postgraduate student, Dr. Roslin, who has taken up this responsibility to present this case. And we are really happy to welcome our State President, Joe sir, and all other members who are present here, Purushottam sir, and many others, and all the faculty and students to this program. I'm sure that this program will be useful for those who are going to have the practical exam of MD in the next 2 weeks. So I'm sure that they should attend all these programs. Next 2 or 3 weeks, we are having MD exams all over Kerala. So I'm sure that they'll get points from this discussion. So thank you once again,
Thank you,
Snu and everyone. And
thank you, Ajit sir. So next I invite dear President Joe sir, who has envisioned this program, which has been ongoing since the beginning of year, every Thursday without an interruption. Thank you very much, sir, for bringing out this program, which has become so very, very popular all over the country. Over to you, Joe sir, for a few words, and we'll quickly move on to the academic session after that.
Thank you, Dr. Vishnu. President IAP Kozhikode, Dr. Ajit Kumar. Secretary Dr. Vishnu. Today, the leading faculty, Dr. Mohandas, and PG students and senior most faculty of our Kerala State, Dr. Purushottam sir, and all the postgraduate students. And I think today we are joined, some of the joined from outside India, some of the faculties of PG students, IAPNs joined together, I understood. I think today this program is very attractive for PG students concerned, where to have a case discussion day every Thursday, every 7:30 p.m. I request all the PGs regarding one issue. I request all the PGs to join IAP membership because we are going to have our annual conference for the chapters are going on, and next week we have hemato-oncology, and next every week we having a state level sub-chapter conference. Along with that, we are going to conduct a free paper and a poster presentation. One thing is very clear, in our IAP platform, all the PG students having IAP membership will only allowed to present our PG poster or presentation. So I request all the PGs to be join IAP as a associate membership. And again, another important part is that we are going to host our state conference at Wayanad. The excellent scientific content and experience hospitality they are arranged. So all the PGs to be requested to attend the program and to present any paper or poster presentation, IAP membership is mandatory. So I request all the PG students to join IAP and to present the paper in the state conference and subject conference in coming weeks. With this wish, I wish all this program Jai Hind, Jai IAP.
Thank you very much, Joe sir. So next, I would like to invite Mohandas sir to take over and proceed with academic session. Over to you, Mohandas sir. Mohandas sir.
ദാസിന് എന്തോ ഓഡിയോ പ്രോബ്ലം എന്ന് പറഞ്ഞിരുന്നു. അപ്പോ അതായിരിക്കും. അപ്പോ ദാസ് അങ്ങനെ ബുദ്ധിമുട്ടുണ്ടെങ്കിൽ മൊബൈലിൽ ജോയിൻ ചെയ്തോളൂ. കുറച്ചു മുമ്പ് ഒരു മെസ്സേജ് ഇട്ടിരുന്നു. അത് എന്താ ചെറിയ
just now notice it. I just saw.
I think Mohandas sir in Idiki. That may be the reason.
അവിടെ ഇത്തിരി നെറ്റ് കണക്ഷൻ പ്രോബ്ലം
അല്ല കോഴിക്കോട് ഉണ്ടെന്ന് തോന്നുന്നു സർ. റിഹാന ആൻഡ് ഡോക്ടർ ഷമീം, പ്ലീസ്
Shamim can start.
Unmute and switch on your video so that we can start.
ഞാൻ സാറൊന്ന് വിളിച്ചു നോക്കട്ടെ, 10 മിനിറ്റ്.
Okay.
കാരണം സാർ ഓൾറെഡി PPT എല്ലാം സാറെ കയ്യിലാണുള്ളത്. സാർ അത് അതുകൊണ്ട് സാറാണ് അത് പ്രൊജക്ട് ചെയ്യുന്നത് തോന്നുന്നു.
Okay.
ഒന്ന് വിളിച്ചു നോക്ക്.
മോൻ സാർ ഉണ്ട്, ഓൺലൈൻ ഉണ്ട്.
Dr. Sadish from Dubai. He joined from Dubai or from India?
You're muted, Satish sir. You can please unmute.
Abu Dhabi.
Abu Dhabi. Okay, very good.
Nice to meet you. Long time.
On time. Okay, thank you joining for our activities. I saw you several times in our activities. You are joining. Very good.
Yeah, thank you. Purushottam sir, thank you.
പുരുഷോത്തം സാർ മ്യൂട്ട് ആണ്. പ്ലീസ് അൺമ്യൂട്ട്.
അല്ല, ദാസ് ജോയിൻ ചെയ്യുന്നു എന്ന് പറഞ്ഞു. അപ്പൊ മൊബൈലിൽ നിന്നായിരിക്കും ജോയിൻ ചെയ്ത് സ്റ്റാർട്ട് ചെയ്യുന്നു.
വീഡിയോ ഓൺ ആയി.
അപ്പൊ നമുക്ക് ജയാറിനൊന്ന് പരിചയപ്പെടായിരുന്നു പ്രസന്റ് ചെയ്യുന്ന. ഷമീമ ഒന്ന് പരിചയപ്പെടുത്തിക്കോ.
Purushottam sir, Dr. Reslin is our postgraduate student at Calicut Medical College, and she is the final year student. One of the best student in our second year. I mean, this our bachelor. Okay, but promptly she agreed to present.
Well, Vishnu, you can invite for your state Pedicon conference.
So
that you are arranged for our wonderful.
So we are hosting the state Pedicon, the annual conference of IAP Kerala at Wayanad this time on the 4th and 5th of November, Saturday and Sunday. So we have one hall completely dedicated for postgraduate students on postgraduate exclusively for case-based discussions, exam-oriented case-based discussions. and another hall again dedicated to very useful topics, right from basics to the advanced, which are very useful in our day-to-day practice and to update ourselves, which involves faculty, cream of the lot faculty from entire country. So I wholeheartedly invite all of you to kindly register for our conference and attend the conference along with the family. November in Wayanad will definitely be a very pleasing climate and a very good occasion for the entire IAP family, IAP Kerala family. As we all know, we move around as a very wonderful family in IAP Kerala. So I request and invite all of you to come and enjoy the camaraderie of IAP Kerala at Wayanad at Vaitiri Village resorts on the 4th and 5th of November. The brochures and the scientific sessions will be shared in all the PG groups that we have been sharing the flyers of PG teaching sessions soon after this program. Mohandas sir.
സാർ ഒന്നുകൂടി വിളിച്ചു നോക്കട്ടെ കേട്ടോ, ഒറ്റ മിനിറ്റ്.
അല്ല
സാർ ഫോൺ എടുക്കുന്നില്ല.
അല്ല സാർ ജോയിൻ ചെയ്തിട്ടുണ്ട്. സാർ ജോയിൻ ചെയ്യുന്ന വേറെ ഡിവൈസിലാണ്. എന്താ സയ്യിദ് സംതിങ് ലൈക്ക് ദാറ്റ്, സയാബ് സയ്യിദ് അൽവി ആണെന്ന് ഐ തിങ്ക് സോ.
സയ്യാഫ് നമ്മളെ കൂടെയുള്ള പ്രസിഡന്റ് ആ നമ്പറില്ല സാറ്?
ഐ തിങ്ക് സാർ ആ പുള്ളിയുടെ കൂട്ടത്തിലാണെന്ന് എനിക്ക് മനസ്സിലായി. പുള്ളി ആ ഡിവൈസിലാണ് ഓപ്പൺ ആയിട്ട് കണ്ടത്.
സാർ ഇപ്പം ജോയിൻ ചെയ്യുന്ന പറഞ്ഞത്, ഇപ്പൊ വിളിച്ചിട്ടുണ്ടായിരുന്നു.
ഹലോ
സർ, വെൽക്കം സർ.
ഇപ്പൊ കേൾക്കാലോ? ഓക്കെ,
കേൾക്കാം പ്ലീസ്.
സോറി.
താങ്ക് യു സർ.
സാർ പറ്റുന്നില്ലേ?
ഞാൻ മറ്റേ സിസ്റ്റത്തിലേക്ക് സ്ലൈഡ്സ് ട്രാൻസ്ഫർ ചെയ്യണം. അല്ലെ റെസ്ലിംഗ് സ്ലൈഡ് സ്റ്റാർട്ട് ചെയ്തിട്ട് തുടങ്ങുമോ? റെസ്ലിംഗ്
ഓക്കെ സാർ, സ്റ്റാർട്ട് ചെയ്യാം.
സോറി റിവർ ചെയ്തു. സ്റ്റാർട്ട് ചെയ്തോളൂ.
ഓക്കെ സാർ. Hello, good evening all. Am I audible?
Yes.
Okay. It's a case of baby of Mashura, 7-month-old boy from Manjeri, informant his mother and it is reliable. Presenting complaint, facial dysmorphism and delay in attaining developmental milestones. And as it is a case of developmental delay, I would like to start from antenatal period. Antenatal history, first trimester, it's a third child of non-consanguineous parents, born to 28-year-old mother and 38-year-old father, detected to be pregnant 1 month after missing her periods. Folic acid tablets taken. There's a history of fever with cough, rhinitis in first trimester, treated with oral medication. No history of any bleeding PV or lymphadenopathy. Dating scan was done and it was normal. Double marker test not advised. Second trimester, quickening felt at 5th month of gestation. History of decreased fetal movements as compared to previous pregnancy. Antenatal scan, anomaly scan showed club foot, otherwise it was normal. Calcium and iron tablets taken. No history of gestational diabetes mellitus, hypertension or hypothyroidism. Third trimester, continued to pursue fetal movements. No history of IUGR, oligohydramnios. No history of bleeding per vaginum or leaking PV. UST normal. Natal history, it was a term normal delivery. Baby cried soon after birth. Birth weight was 2.26 kg. Postnatal history, baby had respiratory distress soon after birth, hence admitted in NICU. Baby was on O2 support for around 9 days. Informed as baby has some dysmorphic features and advised to do karyotyping. And parents not done due to financial constraints. And echocardiography done in newborn period and informed us some minor abnormalities there and which will regress on itself and advised to repeat echo after 6 months. Urine and meconium passed in first 24 hours. Some blood investigation and hearing test was done and were told to be normal. Initially, baby was on nasogastric tube feeding and started direct breastfeeding on neonatal day 9 and discharged on neonatal day 10. And baby had club foods and POP cast done on neonatal day 15 and they continued for 7 weeks and club food was corrected. After discharge from NICU, baby was active, feeding well and gaining weight. History of constipation was there. Initially, baby used to pass stool once in a week. Later, it was once in 10 to 11 days. Now, for last 1 month, constipation resolved. Mother noted delay in attaining developmental milestones. Social smile attained by 3 to 4 months. Baby started rollover by 3 months and head control was attained by 4 months. And node started sitting in tripod position. Bidextrous grasp by 5 months and unidextrous reached by 7 months. Child was looking at objects and starting to sound. Now, child 7-month-old, social smile present, able to roll over and unidextrous reach for objects present. No stranger anxiety or mirror smiling, not sitting with support, not transferring objects. And baby able to laugh loud, but not started speaking monosyllables. Vision and hearing appears normal. Mother also noted floppiness while handling the baby. There was no history of feeding difficulty or recurrent aspiration. No history of abnormal feasting, paucity of movements. No history of seizures. Now admitted with complaining of fever, cough, rhinitis for 3 days duration and loose stool for 2 days. Also complaining of feeding difficulty due to fast breathing. At admission, had fast breathing with increased effort of breathing. Baby was on O2 support for 3 days, given nebulizations, IV medications, and ORS. Now fever, loose stool, and breathing difficulty subsided. Cough decreased. No history of cyanosis or aspiration of feeds. Past history of multiple episodes of cough, fever, and rhinitis present. One episode at 3 months of age required nebulization. No history of previous hospital admission. History of one episode of ear infection at 3 months of age, treated with oral medication and ear drops. No history of any regression of attained milestones. And going to developmental history, gross motor head control attained by 4 months, rollover by 3 months, not able to sit with support. On assessment, developmental quotient 71%. Baby held on pull to sit, no head lag. When held to sitting, held head up and back, keeping back straight. Held standing bears full weight on legs. Developmental age around 5 to 6 months. In fine motor, bidextrous grasp by 5 months and unidextrous grasp by 7 months. Now started transferring objects. On assessment, developmental age around 6 months. Social and adaptive, social smile started at 3 months. Mother regards by 3 to 4 months. No stranger anxiety or mirror smiling. Developmental quotient 42%. Language cooing by 4 months. Laugh loud by 5 months. Not started monosyllables. Developmental quotient 57%. Hearing and vision normal. Immunization BCG taken at 4 months of age. Baby had BCG adenitis at neck and left axilla. Neck swelling ruptured and formed a sinus. Now serosanguinous discharge from the sinus present. Hence parents not willing for further vaccination. Diet history exclusively breastfed till 5.5 months. Complementary feeding started with ragi, getting adequate calorie and proteins. Family history of one spontaneous first trimester abortion in mother. History of intellectual disability and seizure in paternal grandfather's brother. And there is no history of any other developmental delay in family. Socioeconomic status, 5-membered family lives in own house with attached bathroom and 2 bedrooms. Mother studied up to SSLC. She's a homemaker. Father studied up to SSLC. He's a driver. Monthly income 20,000 rupees. Not included under health scheme. Not getting any disability pension. Mother is taking after the child. According to modified Kupusamy scale, they are included under lower middle class family. Summary: 7-month-old boy born to 28-year-old mother out of non-consanguineous marriage with nil significant antenatal history. Noted facial dysmorphism since day 1 of life. Also noticed developmental delay and floppiness while handling the child. Now admitted with complaining of cough, breathing difficulty, and fever for 3 days and loose stool for 2 days duration.
Can I share my slides now, Rasleen?
Okay, sir.
Can you see the screen? Hello? Can you see my screen?
No, sir.
സ്ലൈഡ് കാണുന്നില്ല.
No?
Yes, sir.
Yes.
Okay. So Rasleen has presented the history. Sorry, I could not hear in between also. Some other system also stopped working. Anyway, this is the our baby. So what is the diagnosis here?
you can give answers in chat box if you want. So it is not at all difficult to make a diagnosis here. It is a straightforward case of Down syndrome, isn't it? So how you are making this diagnosis is called diagnosis by Gestalt. So many conditions you can diagnose by just seeing the baby. I'll share a few pictures, and I think almost all of you can make the diagnosis by Gestalt. You can give the answer in chat box. So what is the diagnosis here? You can give the answer. You can speak out also. So what will be the diagnosis here?
Achondroplasia.
Here you can see a child with asymmetry, short stature only by measuring the height we know. And the commonest condition presenting like this is achondroplasia. So it is not at all difficult to make or suspect this child as having achondroplasia just by seeing the child. So what will be the diagnosis here? Anyone?
Prader-Willi.
Prader-Willi.
Here, this is an obese child, you know, and you straight away making the diagnosis of Prader-Willi just by seeing any obese child is not correct. But if you get a history that this child is having abnormal intelligence and all, definitely you have to suspect Prader-Willi syndrome. It is not nice to make a diagnosis of Prader-Willi syndrome just by seeing an obese child. Okay. What will be the diagnosis here?
Rickets.
Rickets. Any other possibility? This you can see that
MPS. MPS.
Here the palm, there is a medial deviation of the
വലിയ പ്രതിഷേധങ്ങൾക്ക് ഇടയാക്കും. ഇന്ത്യ എന്ന പ്രതിപക്ഷ സഖ്യത്തിലെ പ്രധാനികൾ മണിപ്പൂർ സന്ദർശിക്കാൻ പോവുകയാണ്.
ദാസ് റേഞ്ചിൽ പോയി തോന്നുന്നു. വിഷ്ണു എല്ലാരും മ്യൂട്ട് ചെയ്യോ ഒന്നുകൂടി. വിഷ്ണു എല്ലാരും ഒന്ന് മ്യൂട്ട് ചെയ്യോ.
മോദി ഒരു പ്രസ്താവന നടത്തുമോ ഈ പാർലമെന്റിൽ എന്നാണ് ചോദ്യം. സംസ്ഥാനത്തെ മദ്യനയം ആശങ്കപ്പെടുത്തുന്ന പല ഘടകങ്ങൾ കൊണ്ടും
വിഷ്ണു
അതിനെതിരെ ഇടതുപക്ഷ
വിഷ്ണു മ്യൂട്ട് ചെയ്യോ എല്ലാരെയും ഒന്ന്. ഓക്കെ, എനിക്കൊന്ന് ദാസ് ഇസ് നോട്ട് ദ പ്രസന്റ് ചെയ്യുന്ന ആരായിരുന്നു? പ്രസന്റ് ചെയ്യുന്ന ആളുണ്ടോ?
Am I audible now?
Yeah, right.
Okay. Okay, so which type of MPS this will be? This child is having a normal intelligence. Firstly, any answer?
Type 4.
This is a case of Morquio syndrome. So they will present just like rickets initially. Okay. What will be the diagnosis here? This is a child with a developmental delay, and child had a birth weight of 4.5 kg.
Beckwith Friedman.
No. Vector treatment, usually there will be macrosomia, but they have a totally different facies.
Sotos.
Yes, this is a case of Sotos syndrome. You can see frontal prominence, elongated facies, pointed chin. So this is a case of Sotos syndrome. Not difficult to make a gestalt diagnosis. This child with a developmental delay, child is having coarse facies. So most likely this is a storage disorder. And this child is having mucopolysaccharidosis type 2. This child, not at all difficult to make a gestalt diagnosis. What is this?
Cornelia de Lange.
Cornelia de Lange. You can easily make a diagnosis by seeing the excess facial hair, long eyelashes, and typical faces, short nose and all. Okay, so many genetic conditions you can make a diagnosis just by seeing the child. Okay, now you have already presented the antenatal history and all. So here this child is born with a genetic problem like Down syndrome. So how we could have avoided birth of this child with Down syndrome? How will you screen the mother during antenatal period? Is this mother having any risk factor to have a baby with Down syndrome? What is the age of the mother?
28 years old.
28 years. You cannot consider it as a risk factor. There is no history of a previous child with Down syndrome, isn't it? Any history of abortions or any history of first trimester bleeds, which you can call as threatened abortion? Any such history here?
Previous history of one first trimester abortion is there.
Okay. Any first trimester bleeding during this pregnancy?
No, sir.
So many cases you get the history of first trimester bleed in children, in case of children born with the Down syndrome, because it is the nature's effort to expel an abnormal fetus. So here such a history is not there. So would you like to screen this mother if she has presented in the antenatal period? Will you screen this mother for Down syndrome? There is no risk factors anyway.
Yes, we have to offer all pregnant women to screen for Down syndrome. Hello.
Hello.
We have to offer Down syndrome screening for all pregnant women. At 11 to 13 weeks, we have to do double marker and nuchal translucency.
Okay. So suppose you are screening only the mothers who are having an advanced age, say over 35 years. Is it sufficient to prevent Down syndrome, children with Down syndrome, birth of children with Down syndrome?
No, sir. Actually, more risk in mothers with more than 35 years, but there are more fertile group is younger age group. So
yes, exactly, because only a small percentage of children are born to mothers above 35 years. So if you screen only those above 35 years, you will be detecting less than 20% cases of Down syndrome, because almost 80% of children are born to mothers younger than 35 years. So if you want to prevent birth of maximum number of children with the Down syndrome, you have to offer universal screening. So what are the screening methods available?
At first trimester, there is double marker pregnancy associated plasma protein and beta HCG plus nuchal translucency by doing USG. And in second trimester, quadruple test with first trimester screening, it is called as integrated screening.
Okay. So you can screen either in the first trimester or second trimester, and you can offer both sonological and biochemical. And you can detect as high as 95% by combining sonological and biochemical screening methods. So what is there is something called a priori risk. So even before screening, you will be calculating the risk to have Down syndrome. For example, if it is a mother with 35, a mother is having 35 years, what is the approximate risk of having a baby with Down syndrome? What is the general risk in general population, or what? How out of 1,000 deliveries, for out of how many births one child with Down syndrome is born? Approximately
1 in 733 in Nelson.
Okay, it is approximately 1 in 700 to 800. So if the mother is 35 years or older, what will be the approximate risk? At 35 years, it becomes 1 in 250. Okay. So as the age of the mother increases, the risk also increases. Is there any situation where it is associated with advanced paternal age, any genetic condition associated with advanced paternal age? Others can also answer it. The question is not on directed to many of the autosomal dominant conditions with the sporadic inheritance. A child with achondroplasia born to a father or mother with achondroplasia, it is not related to the age of the parents, but a sporadic case of achondroplasia or neurofibromatosis or tuberous sclerosis, such conditions are more related to advanced maternal age. Okay. So what do you know about non-invasive prenatal testing, or NIPT? What is the advantage of this test?
It is a screening test by doing mother's blood. We can test fetal DNA in mother's blood. So it is a non-invasive technique, but it is not available in everywhere.
Okay, it is relatively costlier. The advantage is the other test which we have already discussed, the biochemical screening and sonological screening. We consider we will set a 5% chance of false positivity. That means, so when you get a positive screening, you have to do the confirmatory testing by amniocentesis or chorionic villus sampling. So if you offer first trimester screening to hundreds antenatal women, you will have to do confirmatory test in 5 out of them at least. Whereas in case of NIPT, the false positivity rate is set as 0.5%. So out of 1,000 cases, you will have to do the confirmatory testing only in 5 cases. So the need for doing confirmatory testing is markedly less if you offer non-invasive prenatal testing. That is the advantage. And you can detect many other conditions like trisomy 21, 18, 13, X and Y chromosome anomalies. Only thing is the chance of it is costlier. And it is offered only to high-risk group like women aged 35 years or older, or fetus with ultrasonographic findings that indicate an increased risk of aneuploidy, women with a history of a child affected with a trisomy, a parent carrying a balanced Robertsonian translocation with increased risk of trisomy 13 or trisomy 21, or cases where the first trimester screening is positive and you want to reduce the invasive testing. Such cases you can offer NIP. What about developmental history? What is the developmental quotient?
Developmental quotient 71% in gross motor, 85% in fine motor, and language and social development delays there in this
So what is
case.
the usual pattern? Which domain is more affected in children with Down syndrome?
Language will be more affected.
Language is usually maximally affected. Gross motor, there will be delay, but they usually attain milestones and they walk by around 2 years or so, and like that. But language is the maximally affected. But if you offer proper therapy, they can have a good speech. Which domain is less affected?
Social will be less affected.
Yes, social development is less affected in children with Down syndrome. What about hearing? Hearing and vision, what are the usual involvements?
Hearing conductive hearing loss will be there due to repeated otitis media, and sensory neural hearing loss also can be there as a part of syndrome.
A small percentage of the babies, there can be sensory neural impairments, but a significant percentage of children with Down syndrome develop conductive hearing loss at some stage, some age. So that is the importance of screening or repeatedly testing them for hearing impairment. That is very important for normal language development. What visual problems they can have?
Most commonly refractive errors and early development of cataract will be there.
A small percentage can have, almost 3% of them can have congenital cataract. And in some textbooks say it is as high as 15%.
Okay.
So all these children have to be examined for cataract early infancy itself. So what is the problem with immunization? The child develop BCG adenitis.
Yes, sir.
So is it a contraindication for further vaccination?
Not a contraindication. I counsel the bystanders.
Okay. So this is the pedigree. Can you make it a little bit better? Is it something which is usually what we follow? Is the father is depicted on the left side and the mother on the right side. That's a usual custom. Okay, here it is. The father is on the right side. Okay. So, any other details you will identify in the socio-economic status? Economic status is okay. Then social and something else which is important when you start counseling the family.
Whether they are getting any disability pension or how they are doing therapy.
More than that, they will be having lot of confusion about this problem. They will be thinking that they may have a lot of beliefs. They may think that it is due to some sin they have committed in at some time. like that. They will be having a guilt feeling that it is this sort of children born with mental retardation or some other genetic problem are due to some, they may be having lot of false beliefs. So you should try to identify whether they are having any such things so that you can help them to relieve their anxieties in such aspects so that they can take better care for the child. Have examination.
On general examination, child active, playful, interested in surroundings, afebrile, mild pallor present, left axillary lymph node of size 2 into 2 centimeter, firm, mobile, non-tender, no icterus, cyanosis, clubbing, or edema.
What is the reason for pallor? Any possibility?
Nutritional.
Is the nutrition okay here?
Sir. Other transient abnormal myelopoiesis.
No. Even in children with Down syndrome, the commonest cause of anemia is nutritional. Okay. So, is the nutrition okay, or do you want to modify? The child is only 7 months. Is it the age for nutritional anemia?
Physiological anemia. Actually 7 months old. Till 6 months, baby was on breastfeeding.
So what all efforts you will take to prevent anemia? It's not for a child with Down syndrome, generally.
Generally, during antenatal period, we'll supply iron tablets for pregnant women, and in first 3 months also we'll supply iron tablets for pregnant women, and we can give iron supplementation for all infants.
All infants you supplement iron?
Actually, we are giving only for preterm babies.
What is the first intervention you do to prevent anemia in infancy?
Maternal nutrition.
Okay, to the baby.
Once started weaning, we have to give iron-rich food, and we have to,
in the labor room. In the labor room.
Delayed cord clamping.
Okay, so delayed cord clamping is the very important intervention we all should follow, which is not need any expenditure, but it is very important. The baby will get a few ml of blood extra, and that iron will go to the iron stores, which will help in preventing anemia during infancy. So another thing is low birth weight babies and preterm babies, you have to supplement the iron routinely. In all cases, it is not needed. Okay. Yes.
Vital pulse rate 100 per minute, regular, normal rhythm character, normal volume, all peripheral pulse felt, no radiofemoral or radial delay. Blood pressure 86/60 in right arm in supine position. Respiratory rate 40 per minute. SpO2 90% in room air, and capillary refill time less than 2 seconds.
Any abnormality in the vitals?
Saturation was 90% in room air.
So what do you think the cause is?
This child admitted with fever, cough, and rhinitis. Maybe due to respiratory infection, or it's a case of Down syndrome, can be associated with heart disease.
Respiratory rate is only 40.
Yes, sir.
That is not dyspneic. So do you think it is due to respiratory cause?
More towards the cardiac, endocardial cushion defect will be there. There will be mixing of.
What are the cardiac problems you can are more commonly seen in children with Down syndrome?
VSD, endocardial cushion defect, tetralogy of Fallot.
Okay. So in endocardial cushion defect, SpO2 can be low. In tetralogy of Fallot also it can be low. Okay. So any other cause you can think of? So always you should recheck whether it is a correct reading or not. Okay.
Okay.
Yes.
Head to foot examination, head size normal, anterior fontanel 3 to 3 centimeter, posterior fontanel open, admits tip of finger, flat occiput, temporal balding present, flat facial profile, depressed nasal bridge, eyes, mongoloid slant present, hypertelorism present, epicanthal, bilateral epicanthal fold present, no cataract, low set ears.
Any criteria to diagnose Down syndrome in newborn period?
Hall's criteria,
False criteria. How many components are there?
10.
10. Okay.
Small mouth kept open, tongue appears large, short neck, a sinus in left side of neck with discharge, short fingers, no simian crease or clinodactyly, mild abdominal distension present, no umbilical hernia, sandal gap present, Kennedy crease present, external genitalia normal. Anthropometry, used Down syndrome chart, weight 6.5 kg at 25th centile, length 66 centimeter normal, head circumference 40.5 centimeter at 5th centile, mid-upper circumference 15 centimeter normal, weight for height at 10th centile, normal.
Why should you use a special chart for Down syndrome rather than using a common chart?
Down syndrome growth potential is less in Down syndrome. There will be a shortening. Final height will be less as compared to general population.
So that you can know even by charting it in a normal chart. So what is the advantage of using a Down syndrome specific chart?
Will misinterpret as malnutrition. Growth potential is less in Down syndrome children.
Something is there is no point in taking a normal expected value in a child with Down syndrome. Definitely, you know it is not going to be up to that mark. Then when the parents, when they see that their child is grossly lagging behind, they will be more anxious. So you can easily tell them that child is growing as expected. Even using Down syndrome chart, in some cases, you may see a significant lag in growth, which you have to evaluate. It may be maybe having some other reason. Okay, so it is always better to use a Down syndrome specific chart in this scenario. Any growth charts available, specific growth chart available for any other condition? You know?
I don't know, sir.
For Turner syndrome, there are separate growth charts available. Okay. So here you can see that in the Down syndrome growth chart, child is growing as expected. So in the 50th centile, weight is in the 50th centile, height is above 50th centile, and head circumference is between 25th and 50th centile. So you can easily convince the parents that child is growing as expected. Okay.
System examination.
Yes.
CNS examination. Child alert, active, and interested in surrounding. Cranial nerves normal. Motor system bulk comparable on bilateral. Tone, hypotonia in all 4 limbs. Power, limbs moving actively. More than grade 3 power in all 4 limbs. Deep tendon reflexes normal. Then amiltison angle, adductor angle 160 degree, popliteal 160, and dorsiflexion angle less than 30 degree, scarf sign, elbow crosses midline. Impression hypotonia present. Respiratory system, mild subcostal retraction present, no intercostal retractions, bilateral V's in all chest areas, occasional bilateral crepitations present. Cardiovascular system, apical impulse not visible, apex palpated at left fourth intercostal space lateral to midclavicular line, epigastric impulse palpable, no left parasternal heave, no palpable second heart sound. First and second heart sound heard normally, no murmur.
So SpO2, low SpO2 is not because of a cardiac problem.
Yes, sir. Epigastric impulse was palpable. Actually,
So if clinically normal, CVS is normal, will you investigate the child further or will you stop there?
as it's a case of Down syndrome, we have to screen for any heart disease.
So all children with the Down syndrome should be evaluated for a heart disease, even if the clinical examination is normal.
Yes.
When will you evaluate?
We'll evaluate at birth itself. At newborn period.
In the, preferably in the newborn period. It's not, if otherwise clinically normal, it is not an emergency, but you have to ensure that the heart is normal. Okay, even if clinically normal, you should take an X-ray test, ECG, and an echocardiogram. Okay.
Abdomen, mild abdominal distension is there, soft, non-tender, liver, lower border of liver palpable, 4 cm below right costal margin and midclavicular line, span 5 cm, spleen not palpable.
So is there any hepatomegaly?
No, sir. It's maybe a push down liver.
Why push down?
Child presented with fever, cough, and rhinitis. On examination, had mild respiratory distress with bilateral V's, maybe bronchiolitis.
Suppose the same size, the liver is palpable 4 cm even after completely relieving the respiratory problems. What could be the reason? The liver span is normal, but it is palpable 4 cm below costal margin. And at that time, there is no respiratory problem.
Thorax will be short in Down syndrome.
And any children hypotonia, there can be visceroptosis, isn't it? The ligaments supporting the liver is lax and there can be visceroptosis. And that is the reason you get palpable liver in rickets also. In a case of rickets, you get palpable liver because of the visceroptosis. Okay.
Diagnosis, global developmental delay, central hypotonia, syndromic child, Down phenotype, acute bronchiolitis, BCG adenitis, no protein energy malnutrition, partially immunized.
So you are very reluctant to say it is Down syndrome, right? Any other possibility here?
No, sir.
Definitely, some cases you may, especially in the newborn period and all, you may think that child is having Down syndrome, but on doing karyotyping, it may come as normal. So previously, we used to have only clinical diagnosis, but nowadays, because of easy availability of karyotyping and all cases we do karyotyping before declaring or before definitely saying that it is Down syndrome. Still, here, with all the features, you can make a diagnosis of Down syndrome. Okay. So, how will you proceed?
First, we have to screen. We have to do thyroid investigations first. We have to screen for thyroid function test.
Will you screen now or in the newborn period?
Newborn period itself, we have to screen. Then at 6 months and 1 year. Then yearly we have to screen.
Suppose the thyroid function, there is hypothyroidism in the newborn period. Then how will you proceed?
If it is borderline, like 10, we can repeat. And if it is very high, we have to start thyroxine.
So if it is on repeating also, it is borderline TSH is 10.
Then we have to start thyroxine.
So if the initial screening is normal, you have to repeat at 6 months, 1 year, and then every year. If the screening at any time is abnormal, then you have to initiate treatment and see that the level, the T4 and TSH levels are maintained at the normal level. Okay. Any other investigations you do in the newborn period?
We'll screen for hearing.
That is now done for all babies. So
we can do karyotyping.
Any other screening? Cardiac we have already mentioned. Okay. So you will do karyotyping.
Karyotyping, any other associated anomalies.
What is abnormality in this karyotype?
Trisomy 21.
So you can see 3 chromosomes, 3 21st chromosomes here. So what is this abnormality called?
Non-disjunction.
Non-disjunction. What percentage of children with Down syndrome have this abnormality?
This is the most commonest, 97.
Most common, not most commonest. Shakespeare can say like that, but we usually say yes, most common. Okay. So almost 90, more than 90% of cases, it is
non-disjunction.
Non-disjunction. What is the problem here?
It's 46 chromosome only. It will mosaicism.
To say it is mosaicism, you should see at least 2 karyotypes. So there are only 46 chromosomes, but child is having features suggestive of Down syndrome. What could be the reason?
Translocation.
Which translocation?
Twenty-one.
Here the one of the 21st chromosome is larger than the other.
Yes, sir.
So it is a Robertsonian translocation of 21st chromosome. Okay. What is meant by Robertsonian translocation?
Balanced translocation.
Not balanced. That is totally different concept. Robertsonian translocation is translocation between acrocentric chromosomes. Acrocentric means they have a very, very small PR. Okay. So a normal 21st chromosome is having a very small PR, and the chromosome is mainly composed of QR. So here 2 Q arms in one chromosome, which is almost equal to 2 21st chromosomes. The T arm only is lacking. Okay. So if an individual is having only one such chromosome, that individual will be phenotypically normal. If one of the parent is having a total of 45 chromosomes and the 21st chromosome is this translocated chromosome, that individual will be phenotypically normal. Okay. Suppose you are evaluating, this child has come for consultation. The parents are coming with this karyotype report and they say they want to have one more child. What is the risk of having Down syndrome for their parents?
We'll do screening of parents also. If there is 21 translocation in parents, there is 100% risk of.
Okay, so there is always a tendency to say that as soon as you see the this type of karyotype in the child, you say the risk is 100%. Not like that. In such cases, whenever you see the translocation, you have to evaluate the parents also if they want to have further children. And if one of the parent is having this translocation, the risk is 100%. 21. If a parent is carrying a balanced translocation of 21-21, that means they will be having only 45 chromosome with the this translocated chromosome. Then the risk is 100%. Just because one child is having this, risk is not 100%. Okay. Is it clear?
Yes, sir.
So what percentage of parents you will be doing karyotype? If suppose you are in a genetic clinic and you are having 100 children with the Down syndrome, then what percentage of them, the parents will need karyotyping?
Less than 1%.
Not less than 1%. Generally, the translocation 5 to 8% you can have translocation. So only those having translocation you can advise parental karyotyping. Not in all cases. Okay.
Okay.
What is the abnormality here?
Mosaic
An arrow
is
mark is there, so you can easily identify which chromosome is abnormal.
X chromosome. Klinefelter syndrome.
Can you say?
Klinefelter syndrome.
So the two X chromosomes are not identical, isn't it? So
Yes, sir.
here one X chromosome is having two Q arms, just like you have seen the 21st chromosome. So this is called as isochromosome X. So even though there are two Q arms, the absence of P arm will be responsible for Turner syndrome. Okay. So even with the three Q arms of X chromosome here, this child will be having features of monosomy X or Turner syndrome. Okay. So this is a situation just like this mother, or you can consider this case. In the newborn period, you have evaluated, and so always you look for other anomalies which you expect. The child can have gastrointestinal malformations like duodenal atresia. So that is not there. TSH is more than 100. Echo is having a more perimembranous VSD. OAE pass of the NAD. So how will you counsel? on day 5, you are counseling the parents.
Okay. Now your child is affected with, we are suspecting some genetic disease.
Hello?
Hello.
Am I audible?
Yes, sir.
Hello?
Hello.
Sir, audible ആണ്.
Firstly?
Hello, sir.
കേൾക്കുന്നുണ്ട്. Sir, കേൾക്കുന്നുണ്ട്.
Hello? Shamim, am I audible?
Sir, audible, sir, audible.
Shamim?
Sir, audible ആണ്. Sir പറയുന്നത് കേൾക്കുന്നുണ്ട്.
സമീപ് ദാസിനെ ഒന്ന് വിളിച്ചു നോക്കൂ.
Sir,
ഓഡിയോ
വിളിച്ചു.
കേൾക്കുന്നില്ല.
Sir,
Hello?
വിളിച്ചു. Sir, കേൾക്കുന്നുണ്ട്.
ഇതുവരെ കേൾക്കുന്നുണ്ടായിരുന്നില്ലേ?
Yes,
Sir,
yes.
sir, സാറ് പറയുന്നത് കേൾക്കണ്ടായിരുന്നു.
ആണോ? അല്ല, വേറെ ആരും ഒന്നും സംസാരിക്കുന്നില്ല. റസ്ലീനും ഒന്നും മിണ്ടുന്നുണ്ടായില്ല.
അല്ല സർ, ഞങ്ങൾ ആക്ച്വലി ഓഡിയബിൾ എന്ന് പറയുന്നുണ്ടായിരുന്നു സർ.
ആണല്ലേ? ഓക്കെ, ഓക്കെ. So how will you counsel this situation?
We can counsel like your baby's, we are suspecting a genetic disease in your baby that we can confirm by doing a test called karyotyping. This disease may be associated with severe features like GI malformation, heart disease, but luckily your baby not affected with these features.
So who will counsel? You are in a hospital, there are so many doctors available. Who will counsel?
The person who is taking rounds from labor room. It's if you
Ideally
want
a senior or the person who is having significant experience in counseling such situation is ideal. Okay. Then who all should be present during counseling?
both parents.
Okay. Then from where will you counsel? Will you counsel from the veranda or?
No, in a calm room, both parents should be seated.
Okay. And both parties should have sufficient time. You should not be in a hurry. They also should not be in a hurry. Okay. Then what are the other things you will take care of? So there are certain things you should take care of during breaking the bad news. One is setting up the interview, which we have already mentioned. Then you should assess their perception about the problem. So what are their perceptions? Some will be having thinking that why this happened to me or us. Some parents will say we are not having any problem with our IQ. Then why we have a child with low IQ like that? So they may be having some perception about the problem. So that you should try to understand before telling them the more details. And obtain parents' invitation. They should be listening to you carefully. And they should be demanding for more information. You should not pressure, forcefully give a lot of information to them. So you should sit with them and they will start asking you things and then you can give details. So that is called invitation. And then you should not impart all the details in the first sitting itself. So they may not be ready to hear all the details about Down syndrome. So only the things which are very important initially, that only you will say. And during subsequent sittings, you will give more and more information. And you should have emotional support or empathy. And also, you should summarize, or you can ask them to summarize so that you will know whether you have comprehended in the correct way. Sometimes they, because especially the details about the chromosome, then a chromosome number and all, they may have misconceptions when we tell them. So at the end, you should ensure that they have comprehended properly. Or another thing is mnemonics is breaks, where you collect the background information well in advance before interview itself and during the initial part of the interview. Then you obtain the rapport and you explore details and announce after getting consent and mirroring of emotions. And so these are various mnemonics, but the concept is the same. And some situations, so for example, a child is having an autosomal recessive condition like MSUD. First child is having MSUD and they are coming for counseling. And you will explain the risk and all. 25% recurrence risk and need for doing prenatal testing and all. But they may not be ready to do that. So it should not be considered as a failure actually. So you will be giving the proper information to them and you are empowering them to take their own decision. So the counseling is actually a non-directive thing. You cannot, it is not like prescription. And in case of Down syndrome, you should be telling the positive sides. For example, if there is a congenital heart disease, if it is not there, you can say almost in 40% of cases, we see congenital heart disease, but luckily your child is not having a heart disease. If the child is having a heart disease like VSD, you can say most of the cases very often we have congenital heart disease which need a surgery, but this case we can manage with medicines and we can follow up whether it is subsiding spontaneously. Similarly, hypothyroidism, if it is there, you can say it is good that we have detected early itself so that we can properly treat it. We can very easily you can treat hypothyroidism. Like that's always you should say the positive sides. And regarding the development, you say you can say that child is likely to have delay in attaining milestones, but if you take care of things properly and do proper physiotherapy and all, the child will attain milestones faster than if you are not doing anything. So you can motivate them to take care of the child. And another thing is many parents think that the name Down syndrome is because the child is down in all domains. So just by hearing the name Down syndrome, they will get depressed. So you can explain why this name has come. It is just a name of a doctor who first described this condition. And it is always better to use the term trisomy 21 than Down syndrome. Trisomy 21 gives a better picture about the cause of this condition. You can easily explain regarding when you explain the chromosome number and all, you can introduce the term trisomy 21 so that they will better understand what is wrong with the child. And you can explain. So you should know the educational status or how much they can comprehend before explaining all these things like chromosomes, aneuploidy, like that. So what is World Down Syndrome Day?
March 21st.
March 21st. And the Rare Disease Day is on February 28. Okay. So one important problem you have when you following up the child is regarding development of atlantoaxial dislocation. So that has to be suspected if child is having any recent change in behavior or easy fatigability, recent dislike in participating in games, change in hand preference, gait changes or difficulty in walking, spasticity, urinary incontinence, sensory symptoms, neck pain or limited neck mobility, or incoordination or clumsiness. So when any of these are there, you have to suspect atlantoaxial dislocation and you have to investigate. There is no much point in screening with an X-ray of the cervical spines, because it is very difficult to interpret that. Any other genetic condition where there is increased risk of atlantoaxial dislocation?
Achondroplasia.
Achondroplasia. Anything else? You have seen the picture initially itself. Morchio, there is very significant risk of atlantoaxial dislocation. Any points to discuss? Purushottam sir, any comments or any points to discuss? I have not touched all the aspects.
It was an excellent discussion. There was some problem with the connection, so that's all. Just a few points I noticed about regarding folic acid therapy. In the history part, the folic acid therapy should have mentioned very conceptual folic acid. It's not merely enough to say folic acid. About the distress, when you mention about the distress in a term baby with adequate 2.65 gram at term distress soon after delivery, rather than soon after delivery exactly after how many hours, because the distress you are not expecting in this case because of the prematurity, not because of the HIE, but as we said, both are not there. So the distress onset will give a clue towards the possibility of a congenital heart disease. So soon after birth is a vague term. So what was the time of onset of the distress and the cause of the distress is important in any case where you suspect the possibility of a cardiac problem. Another one, you describe the possible club foot. So in any newborn baby with a club foot, especially in a dysmorphic child, always suspect the possibility of a lower spinal cord malformation. Always exclude the possibility by mentioning the power of the movement of the lower limb, anal tone, dribbling of the urine, because you consider this possibility of a spinal malformations. And very important, in the newborn, we should be mentioning about the neonatal screening programs. So Salabam program, in this case, they didn't, were not billing for the karyotyping, but if it is a government hospital, all this program out of this thing, hearing, vision, the pulse oximetry, especially in this case, is important. Inbound of metabolism, visible birth defect, these Jadaka Seva, and also there may be a question based on the neonatal screening program and the Salabam. So that's very important. And during the development, when you present the developmental history, there was some point noticed. See, at 3 months turning over, so it cannot be possible. So head control achieved at 4 months and turning over at 3 months. So that is a bit, always it should be following the normal the rules of the development always should be respecting in whatever problem. So that paradoxical statement was wrong. So when the baby developed pallor, of course, other possibilities are there, but a Down syndrome child developing pallor somewhere at 6 months, one of the hematological complications of Down syndrome need to be considered. So you need to check the transient myelodysplastic problem, hematological problem. So lymph node, in this case, organomegaly is not there, but in the investigation also, you need to mention about that peripheral smear and hemoglobin part. And then one of the thing, we didn't have an explanation for the 90% pulse oximetry. So your explanation was respiratory. There, what you need to do is look during crying. So what is happening during the crying is very important. If the saturation is not improving, you need to consider possibility of a cardiovascular problem. In a case where there is a chance of cardiovascular involvement, echo done in the newborn period should not be totally relied upon, because there is a possibility always missing other cardiac problems. So always that point need to be considered. So you need to tell about the weight gain following the newborn period onwards. That is the point. So you discuss the, during the cyanosis, you discuss the one possibility of endocardial cushion defect, because endocardial cushion defect is a condition with failure. The gain in weight will be affected and symptomatic. So even when you're getting a cyanotic situation, cry weakens, desaturation increase on cry, it's not the ECD, but the possibility of a fallow. In a Down syndrome, in newborn period, it is missed and later found out. So that is the small problems which would have improved in the presentation. That's all. Otherwise, all the points were covered, thus discussed very well. And the points which are unlikely to be discussed also included. The neonatal counseling part is very important. And other thing also, which all of you should be remembering, is the programs which are important. There are a lot of programs in this group of people. What are the rights? Are we giving that? Those things, if it is a little older child, that part is very important. And one thing, in the socio-economic part you discuss, but the social thing, the caregiver burden is very, very important. The attitude of the mother, the job or financial source of the mother, and there are two elder siblings that we may be usually ignoring that part. The caregiver burden is the burden for the mother, and the elder siblings will be affected when a genetically problematic child is born. So that also is one of the social situations which we need to consider. So that's all. Thank you, Dasan.
Shamim. Shamim.
Sir, I think sir has discussed almost everything, sir. There is nothing much thing to add.
Other participants, any doubts or Vishnu?
Wind up here. Thank you very much, Mohandas sir and team, for that wonderful discussion. So on behalf of IAP Kozhikode and IAP Kerala, I thank wholeheartedly all of you for joining us for this wonderful teaching session. Thank you.
Actually, I was traveling back from Idukki today. I was not knowing the program was today. And on the way to Calicut, I came to know it is. And now I am in my friend's home in Thrissur, Dr. Sajeevan's home. That may be all the pictures initially. Okay, thank you.
Thank you, sir. Thank you very much.
Good night, everybody. Bye.
Good day. Thank you.